على أشرف المرسلين سيدنا محمد وعلى آله وصحبه ومن تبعهم بإحسان إلى يوم الدين. السلام عليكم ورحمة الله وبركاته. Good evening. I am Mohammed Shahrani, pediatric hematologist, oncologist, and bone marrow transplantation at Prince Sultan Military Medical City in Riyadh. I would like to thank the Saudi Society for Blood Disorder for giving me this great opportunity to be with you tonight. We do have 3 eminent speakers tonight. They will explore a very important topic. It's the update on hemophilia management. I'm delighted and honored to introduce Dr. Paul Jan Grandi. Dr. Paul Jan Grandi has retired from his position as a consultant hematologist at the Oxford University Hospital and director of the Oxford Hemophilia and Thrombosis Center. However, he remains a member of the Department of Clinical and Laboratory Science in the University of Oxford. He qualified in medicine in the University of Manchester after previously earning a first-class Bachelor of Science degree in the pharmacology. After obtaining his postgraduate qualification in both adult and pediatric medicine, he trained in hematology at various major hospitals in London, as well as Basel at Switzerland and Milan with Professor Manouchi. He earned a research doctorate for his work at the Royal Free Hospital in London on immunological aspect of hemophilia treatment. Dr. Jan Grandi has a wide international experience in the field of hemophilia. He served as chairman of the Medical Advisory Board of the European Hemophilia Consortium from 2013-2018 inclusive, and also as elected vice president medical part of the World Federation of Hemophilia from 2000-2008. Dr. Jan Grandi has a wide list of publications. He will explore acquired hemophilia guideline. So before we start, I would like on behalf of you to thank our host, SSPD, and our sponsor, Novo Nordics. We will leave all the questions after all the 3 speakers, the talk, and please kindly post your question at the Q&A questions, and we'll ask our speaker to answer. This webinar will be recorded and it will be, inshallah, posted in the SSPD website. So, Dr. Jan Grandi, the floor is yours. You have 25 minutes.
Thank you very much, Dr. Al-Shahrani. It's a pleasure to be able to speak to you this evening in Saudi Arabia. I'm only sorry that I can't be there in person with you, but I hope that soon I will be able to visit you, and anyone who comes to the UK from your group, I'd be delighted to host a visit if you come and see me here in Oxford. I'm going to talk about some guidelines on acquired haemophilia. And I think this is quite an important thing, because these guidelines, which were published just a couple of months ago in the July issue of Hematologica, are really updated and international recommendations that come from an international group that I was honored to be part of. And these really update recommendations that were published as long ago as 2009, so 11 years previously. You can download this article free of charge because it's an open access article, and it contains a considerable review of the literature as well. So I think I commend it to your attention. Now, I appreciate that among the audience here, we have a number of really expert physicians who know much of what I'm going to say in my introduction. But I was specifically asked to give some opening slides talking about acquired haemophilia in general before I get down to talking about specific guidelines. I hope this is of interest to the younger members of the audience, but forgive me, you expert physicians in the audience, if I tell you things you already know. Of course, acquired haemophilia is a rare disorder affecting females just as much as men, and predominantly elderly patients. The clinical manifestations are very different. We don't see joint bleeds frequently, but cutaneous purpura are the hallmark. And very importantly, in contrast to congenital haemophilia, there is no clear correlation between the factor VIII level and the severity of the bleeding. That is, in congenital haemophilia, we tend to think of people with a factor VIII level of less than 1% as those prone to more serious bleeds. But people with acquired haemophilia can have a serious bleeding tendency with a factor VIII level of 3 or 4%. And indeed, there's a very significant mortality from the bleeding in acquired haemophilia. These are the typical cutaneous purpurae we see in acquired haemophilia. The reasons for this manifestation in acquired compared to congenital haemophilia is absolutely unknown and is a fertile area for future research, which perhaps a younger member of the audience might wish to embark upon. We know from two major studies, the 2007 UK study and the larger, over 500 patients, European registry, that about half the patients with acquired haemophilia have no obvious underlying condition. By contrast, the other half, there is a clear association with a number of underlying conditions ranging from other autoimmune conditions, malignancy, and pregnancy. And if we look at the age distribution, and we see in the dark blue, we see male, and in the lighter blue, we see the female distribution, we see that the median age of these patients is in the 70s, and we see roughly a 50-50 split between males and females, apart from in this younger group here, where we see a predominance of females, and these, of course, are the postpartum acquired haemophilia cases. Now, if we look at a series historically, what we note is that the mortality has certainly improved. The mortality is as now is as bad as it was in previous studies published some years ago. By contrast, we see that there's been a definite decline in the mortality specifically associated with bleed. So we have better agents to manage the bleeding complications. So while the mortality remains high with this condition, the actual fatality due to bleeding is unfortunately coming under control. Now, the diagnosis, I don't need to tell you, is based on the factor VIII level and the mixing studies. I think it's true to say that sometimes the heat inactivation of test plasma may improve assay sensitivity. This is true of congenital haemophilia, but it's also true specifically of acquired haemophilia, and I quote a specific paper in this regard. Now, one of the problems that we have is that many of these patients being elderly, we have a problem in the differential diagnosis between acquired haemophilia causing inhibition and prolongation of the APTT and the lupus anticoagulant. And one way we can get round this is to use a chromogenic factor VIII assay, because a chromogenic factor VIII assay is insensitive to the presence of heparin, for that matter, as well as the lupus anticoagulant. And the reason for this appears to be purely a dilutional effect, and that is the plasma is much more diluted in the two-stage chromogenic assay than it is in the one-stage assay. Now, a point which really needs to be emphasized and is not commonly understood by many, even expert clinicians, is that the inhibitors in acquired haemophilia show different kinetics from congenital haemophilia, and I'm going to show you a graphic in the next slide, the type 2 kinetics. And the point is that the classic Bethesda assay we use to assay the strength and potency of an antibody in congenital haemophilia misleads us in acquired haemophilia. We underestimate the true potency of the antibody. So in fact, we get a false impression that the potency of the antibody is underestimated. Now, this is a slide taken from a very old publication, but we see here what happens when you look at the factor VIII assay in someone with acquired haemophilia. So we've taken a test tube, it's got a source of factor VIII, we add the plasma from someone with acquired haemophilia, and if somebody had congenital haemophilia and an inhibitor, we would see a linear decline, fairly rapid, the classic type 1 inhibitor. But in the patient with acquired haemophilia, we see actually a rapid initial drop, and then it falls off. And you may think, well, perhaps we have a residual factor VIII level because the antibody has been saturated, its potency is low. So if we add at this stage factor VIII, what we notice is the factor VIII level goes up. So there is, and then it starts to decline again. And this shows us that the antibody has not been saturated. There is still very active antibody there. It's just that the kinetics are very slow. And if we're looking at a 1 or 2 incubation period, we are grossly underestimating the true potency of this antibody. And of course, there are a number of clinical and ethical challenges. Many of these patients don't present to us as hematologists. They go to colleagues in other disciplines, colleagues who are often not aware of the condition of acquired haemophilia, and the disorder is often mistaken for other conditions, and there is often a delay in the diagnosis, particularly if laboratory testing facilities are limited. And of course, these elderly patients are often frail, and we have a number of ethical challenges. How far do we investigate these older, frailer patients for an underlying disorder? There may be issues of informed consent and mental state, and the willingness sometimes of health insurance agencies to spend large amounts of money on their treatment. And of course, these older patients are very sensitive to the side effects of the drugs we'll be using, such as cytotoxic agents and steroids. And the management, as you know, consists of two specific arms: stopping the bleeding with a hemostatic agent, and then eradicating the inhibitor. And for that we use immunosuppression. And of course, avoiding anything that's likely to provoke a bleed. And at the same time, let's look at then the management of the bleeds. And hemostatic agents, I'm going to be talking about these three agents on the understanding that in the great majority of cases, human factor VIII is going to be most unlikely to work unless the antibody level is very low. The general management guidelines that are in these published paper here are set out here. Notice that most of the patients will require some form of treatment with a hemostatic agent. About 30% of them in the UK and European registries didn't. And of course, if patients just have cutaneous purpura and they're hemodynamically stable with a good hemoglobin level, then they're not going to need bypassing agents. And of course, we know, this is not new, that bypassing agents are much more likely to yield good clinical results than using either factor VIII or desmopressin. I'm not going to argue that of the two bypassing agents we'll be talking about, Novo-7 or FIBA, there's a significant difference. The data show very clearly that both are equally effective, and we have a 93% response rate in the large H2 registry. Obviously, treatment of the underlying condition may help, and bear in mind many of these patients, by virtue of being elderly, are at risk of both arterial and venous thromboembolism, and we have to bear that in mind, bearing in mind that tranexamic acid in particular can cause thrombosis in some of these subjects. Let's look at the three agents, and the data that I'm presenting here are set out in detail in the guidelines published back in July. If we look at recombinant activated factor VII, there are data from a number of sources, including emergency and compassionate use programs, patient registries, and surveillance studies, and there have been at least two systematic reviews. The standard dose is the same dose that we would use in congenital hemophilia, namely 90 micrograms per kilogram for an initial bleed. And if we look at the large number of patients specifically with acquired hemophilia that have been treated, we see a satisfactory response. If we look at activated prothrombin complex concentrates, and of course I'm talking about FIBA, whilst there's no systematic review of the use of this product specifically in acquired hemophilia, we know that it is very effective. And of course, the recommended dose, as in congenital hemophilia, is set out in this second line. There was an interesting Italian study that was published just last year. This was a prospective study looking at a large number of patients treated around Italy, and I thought there was some interesting data. Firstly, the high efficacy of FIBA. I was also interested to note, and these data are set out in the guidelines we published back in July, quite a significant proportion of the patients were treated with tranexamic acid, and despite this, there were no thromboembolic events. Of course, FIBA does contain trace amounts of factor VIII, and it's therefore not surprising to see that the Italian study showed that in a minority of patients, there was an anamnestic response, that is a rise in the factor antibody titer, typically 2 or 3 weeks after treatment with FIBA. Now, forgive me for talking about porcine factor VIII, that is of pig origin, it's a recombinant product. Of course, I'm well aware that this is not a product that you're going to be using in the Kingdom of Saudi Arabia, but because it's mentioned in the guidelines, it's something I really feel obliged to talk about, despite the fact that you're not going to use it. This recombinant product, of course, takes over from a plasma-derived product we used many years ago, and in the initial pivotal study that was published, the licensed dose was set at 200 units per kilogram as at the initial dose, although there is very good evidence from subsequent clinical work that an initial dose of 100 units per kilogram appears to be sufficient for most patients. One of the good things about porcine factor VIII is that we can measure a factor VIII level in the body. And that's very useful for many clinicians, because it's very difficult to monitor the treatment with febrile or Novo 7 in a laboratory setting. And of course, we use porcine factor VIII because it's sufficiently similar in structure to human factor VIII to work like normal factor VIII, but at the same time, it's sufficiently different in structure to avoid interaction with the inhibitory antibodies. Having said that, inevitably after treatment with several courses of porcine factor VIII, you will see the development of inhibitory antibodies specifically directed against porcine factor VIII. And this can and will prompt you to have to stop treatment at this stage. This was a very recent study that comes out of the German thrombosis and hemophilia study. And what it's actually showing is, in a study of 70 patients, in a prospective study of patients with inhibitors in the German-speaking world, that is Switzerland, Austria, and Germany, almost half the patients did in fact have some cross-reactivity between human and porcine factor VIII up front. And this was almost all the patients where the anti-human titer was greater than 100 Bethesda units. Most of these patients would be unlikely to respond to porcine factor VIII because of the high degree of cross-reactivity in the high titer patients. So let's turn to the question of immunosuppression. As you all know, we recommend immunosuppression with a combination of prednisolone and cyclophosphamide. And the data indicate that the majority of patients, up to 80%, will respond after a median of 5 to 6 weeks. That's longer than many patients, many physicians feel is necessary for treatment. Of course, cyclophosphamide is not safe during pregnancy or lactation, and that's a clear contraindication in the postpartum cases of acquired hemophilia. And without going into the details, it's very clear that a combination of steroids and cyclophosphamide is much more likely to yield a better result, although obviously it's much more likely to result in adverse events. Interestingly, the combination of steroids and cyclophosphamide doesn't seem to improve the long-term survival of patients, but you get a better remission rate right up at the beginning. Now, interestingly, as we comment in the paper, the data from the German study clearly identifies a factor VIII level at diagnosis in acquired hemophilia as a poor prognostic indicator. And so the authors this German study advocate a tiered approach. That is, because patients with a factor VIII level of less than 1% are much more likely to relapse and have a poor prognosis, the authors advocate an individualized treatment approach. If you've got a factor VIII level of more than 1% and a low inhibitor titer, then you can treat these patients with steroids alone. And many physicians now reserve the combination of steroids and a cytotoxic agent just for those patients with a factor VIII level of less than 1% at diagnosis or an inhibitor titer greater than 20 Bethesda units. I'll come back to the issue of rituximab in a moment. So we know from several studies that an initial factor VIII level of less than 1% is associated with lower remission and survival rates. Overall, in acquired hemophilia, the relapse rate is around 20% after 6 months, and these patients need to be monitored closely as outpatients. It's been known for some time, again from the German group, that patients with anti-factor VIII autoantibodies that are of the IgA subclass appear to have a particularly high risk of relapse. But this is not an easy test to carry out, and it's certainly something that we've never done here in Oxford or indeed in the UK. Much more importantly, a French study published just last year showed that a decrease in the factor VIII von Willebrand factor antigen ratio seems to be an early and useful indicator of relapse, so I commend that paper to your attention. Despite initial enthusiasm for the use of rituximab, this is no longer recommended as initial monotherapy, and the reason for that is that the studies have shown a lower remission rate compared with conventional therapy. I've quoted a figure of 42% with the EACH2 study. And so for this reason, rituximab is really best reserved as initial therapy, at least, only to those patients where steroids are contraindicated. Now, what about alternative therapies? Well, I've talked about rituximab as first-line therapy. You might want to consider rituximab at one of two classic doses, really for second-line therapy and management of relapse. People have used cyclosporine quite usefully in the past, and I've certainly used that. But of course, emicizumab is the big thing to talk about. We say in the guidelines published back in July that emicizumab, of course, which is not licensed yet for the use of treatment of patients with acquired hemophilia, that it's not recommended outside the setting of formal clinical trials. But of course, there have been several recent reports of successful use. Paul Knobel, who is indeed one of the co-authors of the guidelines I'm talking about, recently published in Blood a series of 12 patients where emicizumab was used very successfully in treating patients without any complications. Of course, emicizumab I think is likely, therefore, to become a drug which in the future will formally be licensed, but at present it's not. Of course, the fact that this antibody persists in the circulation for up to 6 months, as you well know, complicates the follow-up of these patients in terms of monitoring the factor VIII level, because of course you have to use bovine reagents, and at the same time rather restricts the choice of bypassing agent you might want to use. So I was originally given 20 minutes to talk about this, and I'm not going to read out the the principal conclusions here, but I would invite you to download the guidelines, which I hope are of use to you. So thank you very much, and I'd be delighted to take any questions at any stage you wish.
Oh, thank you so much, Dr. Giangrandi. It was an excellent journey in acquired hemophilia. Thank you so much.
Okay.
So we'll leave the question at the end of the talk.
Okay, thank you.
We'll take the next speaker. The next speaker is Dr. Tariq Uwaida. I'm sure everybody knows Dr. Tariq Uwaida. He's a professor at Al Faisal University and consultant hematologist at King Faisal Special Hospital Research Center in Riyadh. Dr. Uwaida, he is one of the experts in the hematology laboratory and one of the founders of who had a great role in the development of this field. He has a major role in the bleeding disorders and thrombosis diagnostic as well as management. He is well known locally, nationally, and internationally. Both Dr. Hazza and Dr. Tariq well connected to World Federation of Hemophilia, and both were established of Saudi Society of Hemophilia with other colleagues at King Faisal Special Hospital in Riyadh. Dr. Uwaida has many publications involved in many committees as a leader as well as participant. He will talk about World Federation of Hemophilia guidelines. Dr. Uwaida, the floor is yours. Can you mute yourself, yeah, Dr. Tariq?
Okay, now.
We cannot hear you. Okay.
Yeah. Assalamu alaikum. Thank you, Muhammad. Sorry, I was talking to myself. That's part of the problem of using these unseen symposia or workshop. It's a pleasure to be with you tonight and share with colleagues Paul and Hazza the updates about management of patients with hemophilia. As Paul had gone through the guidelines for the acquired hemophilia, I will be talking more about managing congenital hemophilia. It's a big topic, so I'll try to shed light on some of the new things, some of the updates that happened in the new WFH guidelines. As we are starting with more than 200 participants with different backgrounds. Let me just give you some background about the hemophilia, which just to put the ground to start the how to manage patients with congenital hemophilia. As we all know that hemophilia is an X-linked congenital bleeding disorders, be it factor 8, hemophilia A, or be it factor P, hemophilia of factor 9. In all over, the WFH annual global survey estimate approximately 400,000 individuals with hemophilia all over the world. And hemophilia A is considered to be the most common one, representing 80 to 85 of total hemophilia, and leaving a small portion only for hemophilia B. Both 8 and 9 genes are on X chromosomes, and almost a third of the cases are as a result of de novo mutations. We all know the clinical manifestation of these bleeding disorders are peculiar because patients with hemophilia have a bleeding tendency, and these patients can be mild, not noticed, and can be excessively severe in form of frequent episodes of different types of deep joint and muscles bleeding. Some children with severe hemophilia may not have bleeding symptoms until later when they become more active and start walking. And that's why sometimes, especially in mild and moderate types of hemophilia, the diagnosis of children can be delayed to 1 year or more. As you all know that the severity of the disease depend on the clotting factor, and the diagnosis of that definitely happen through measurements of that clotting factor. The WHO WFH guidelines had divided, again, this is not the new one, but the old one, and it's still the same concept, that the patients with hemophilia can either present with serious bleeding, that's mainly hemarthrosis and joint muscle bleeding, life-threatening when it involves intracranial or gastrointestinal, and sometimes, and that's represent almost 70 to 80% of the bleeds. While other mild bleeding can happen as an epistaxis or mild bleeding post-injury. When it comes to the care of patients with hemophilia, there are principles that have been set up long time ago, and most of the practicing physician dealing with patients with hemophilia adopting most of these principles, which had proven over time that these are the pillars for making sure that the patients with hemophilia live normal to close to normal life. The primary aim of the care of patients of hemophilia is to prevent as much as we can the bleeding, and when it happens, we need to start early to treat the bleeding. The other principle is when there is a bleeding, a specific factor deficiency should be treated with the concentrate, and we will talk a bit more about the concentrates and the updates about the therapy in hemophilia, including the gene therapy that later will be dealt with by Hazza. The overall management of patients with hemophilia had been shown to be better care when there is a comprehensive care settings. And that's, again, some of the development that's been emphasized over many years, that the patients with hemophilia is not like other patients. They have many complications. They need more care providers to be involved in management, and having this comprehensive care would result in better life for these patients with decrease in morbidity and mortality. The wide range need of these patients and their family to this comprehensive care is beyond the doubt, and it's in practice in most of the countries, including in Saudi Arabia, which been started 20 years, and I'm happy to see now more and more centers applying the multidisciplinary team of healthcare professionals that help the patient, where the patient is the center in this care, and everybody else is working around to make the life of this patient is more good. When it comes to the journey of care of a bleeding patient, it starts usually with the diagnosis. And we all know that diagnostic tests that are needed is basically the basic diagnostic test with BT, BTT, and that will have a prolonged BTT, where that will be an initial steps showing a patient who is having abnormal coagulation test, and that would lead to factor assays. And I will shed a little bit of light on factor assay and what is the updates in the factor assay, and that will be complemented by later as the patient start to receive treatment to measure the inhibitor and see if that patient has started to develop inhibitor. When there is a need, there is a molecular genetic that will help in special situation. I will not touch because of the time constraints. I will leave that. And definitely the internal and external quality control are very important components when it comes to the laboratory diagnosis, and needs a lot of emphasis to be practiced in most of patient or laboratories dealing with patients with hemophilia. So what is needed for medical treatment? And for our colleagues who are starting taking care of patients with hemophilia, the basic medical knowledge is important. Patients need, the practitioners need to know about the hemophilia in depth, because these patients are not like other patients. They get exposed to many factors. They get exposed to a lot of types of medications, and a lack of the knowledge may result in suboptimal management of these patients. Not only the knowledge that will be in the physician pool, but trained nurses are as important as the physician, because they are the frontliners and they will receive the patient and need to deal with patients. If you start treating patients with hemophilia, you need to know, and you need to make factors, concentrates, or alternative to concentrates available, so that will be your tool to stop the bleeding and prevent the bleeding. Other adjunctive therapy like FFP, cryoprecipitate, antifibrinolytic, all these can be of value, but definitely nowadays it's not acceptable to use these without having a factor concentrate, which is available in most of the centers. With this complicated treatment modules for these patients, guidelines for management of hemophilia patient became the one of the focus long time, and that because these guidelines would contain several recommendations that will help care providers at all levels to deliver the best established evidence of based knowledge for treatment of these patients. It would unify the application of diversity of the healthcare services and address economy to deliver that service in a cost-directed manner. It would standardize the management approach within the hospital, the country, and the patient when moves from one center to another center, likely to receive adequate or the same standard of practice. And that's on a global level was the goal of the WFH when they start releasing their guidelines. It would encourage the practice harmonization around the world, and that's one of the major goals of the WFH guidelines. So what are the guidelines content? Any guidelines, be it a local guideline or an international guideline should have a general care and management of hemophilia information. And that should be emphasized because that will be the first step in taking care of these type of patients. It should focus on comprehensive care and address all aspects of comprehensive care in details and define the rules of each one or each member of the comprehensive care, and that would help especially starting institutes to teach their staff how to deal with patients with hemophilia. The guidelines explore the diagnostic issues, but all the issues that may face from pre-analytical to the reporting of the factor, with all the updates that happens, as I will show you with the new guidelines. These updates will help a practitioner to be updated about changes in the management that would result in the diagnostic dilemmas that needs to be addressed during testing for these patients. Various management issues, orthopedic issues, surgeries, and all these has to be included. The guidelines cannot be completed without exploring the prophylaxis, its application, its type, when to start, what type of prophylaxis, and it will address the factor replacement options, the factor and non-factor, as we will hear, option for the treatment of these patients, and definitely will advise what these patients needs to do during invasive procedures, dental, home, and pain managements. There are many guidelines. If you go to around the world, you will find guidelines in Australia, in UK, as been alluded by Paul. In Saudi, we had worked on the guidelines in 2010, and we are working on the second version of the guidelines, hopefully this year, early next year. And if you look at the WFH, they started their guidelines earlier. I have the 2012, the 2016, and now we have the 2020. All these guidelines are coming, as I mentioned, on periodical to update the practitioner of any updates and change in the practice that happens over time. The definitions of replacement of therapy is different, but as been adopted by the WFH long time, it can be divided to episodics or on demand, which we give the patient the treatment whenever there is a bleeding, and that's been in practice for many years, and I think in many places is still in practice. With the start of the prophylaxis decades ago, that shown the efficacy and improvement in the total care. And that prophylaxis, again, I will not go in details because of the time. It could be primary prophylaxis, secondary prophylaxis, or tertiary prophylaxis, or even intermediate periodic prophylaxis. All these had been dealt and had been defined clearly in the guidelines, and the benefits of each one each one of these protocols had been explored in details. The administration and dosing schedules had been also been elaborated, and options being given to the treaters, the usual MALMU, the ARTECT protocol, and as well as the low dose protocol that I will again highlight on in the new guidelines. There are barriers for prophylaxis. We all know that prophylaxis is not an easy thing. It's not even easy to convince, especially for patients with pediatrics groups where there is a problem of access to the venous access for the therapy, inconvenience, frequent visits, the factor availability, the cost of the factor, the type of the factor, and the inhibitor developments. All these are barriers, but we have, with the help of WFH, had promoted the prophylaxis and consumption of the drugs to improve the patient status with different ranges, ranging from, as you can see, 100% in areas, including one of our neighborhood area, Bahrain, to as low as almost zero on some of the areas, maybe because of the reporting, but definitely there are areas where the prophylaxis and the consumption of factors are so low because of many reasons. Pharmacokinetics is one of the tools had been adopted in the last few years. Again, unfortunately, this one had been moved the slide out. The new guidelines, which is here, you can see that some of the patients with lean body may be effectively treated with reducing costs of treatment based on body weight and pharmacokinetics, and this is being addressed in the new guidelines. How to measure the pharmacokinetics, how to do it, all these had been elaborated, and because of the time, again, I would ask you later to refer to the full text of the guidelines. Home therapy had been emphasized not only in the new guidelines, but it was emphasized from the previous guidelines, which had made a lot of difference, especially for people who have difficulty to reach hospitals. Many companies had bought a lot of funding to support hospitals and institutes and programs to move the care from hospital to home, particularly for patients who are on prophylaxis. I will skip this and highlight only few points about lab issues regarding monitoring of therapy. Two things had came up with the new guidelines, and these are the additional information on the assays, more focus about the one-stage and chromogenics, and the differences that be noticed with different types of concentrates, and a lot of emphasis on which type of concentrate you need to use if the patient is receiving recombinant or B-domain truncated, and again, a lot of details. I'll ask you to please go and get more about it from the main document. The other thing, which is the introduction of emicizumab, had been talked about in the new guidelines, and particularly the effect of the emicizumab on the testing, as we all know, because of the nature of the bypassing nature of the emicizumab, the ABTT become overreactive, normalized at very low concentration of emicizumab, and should not be looked at or used as a monitoring tool for patients started with emicizumab, as well as the one-stage clotting assay have the same problem, should not be used for measurements of endogenous or exogenous factor VIII. What we need to do, we have the factor VIII chromogenic assay, and that factor VIII chromogenic assay could be bovine, and that's insensitive to emicizumab, and it's a good test to be used for measurements of endogenous or exogenous infused factor VIII. And if you would like to measure the activity of emicizumab, the humanized factor VIII chromogenic can be used for that. The guidelines had been published in the Hemophilia, and you can see all the famous names from clinical, from laboratory, and people who worked on the gene therapy like Glenn Bears, all had put a lot of effort and a nice document that has a lot of information, evidence-based and guidance. And I'll just give you a snapshot in, I think in 2 minutes about the things that had been elaborated in the new guidelines. Other than that, I talked about it. The genetic assessment had been explored more here with more new information. The therapy and the type of products, innovative therapies, the long-acting and the non-factor had been added to the document. So more information about these new factors, which had been some of them been in practice and some still under clinical trials. There are few points had been explored in details in chapter 5 and 6, discussing the clotting factor concentrate and for patients with hemophilia who WFH does not express pre-found for recombinant of a plasma, and that's again, as we all know from the CIBIT study, but they brought all the things in front of the reader. So the choice between these classes of product must be made according to the criteria, including availability, the cost, and the patient preference. And that's we all know, most of the people agreed, especially after CIBIT, that the difference is not big. Actually, it's in favor of the plasma drive, but still the recombinant is a good option. They had explored all the types of prophylaxis, and again, all the types of drugs that still in clinical trials, which we hope that it will be coming soon. The hemophilia, the WFH also had some recommendation about the half-life and the dosing of the half-life. Again, I will not go in details. Please go and see what they had recommended for extended half-life and the use of pharmacokinetic for that. The low dose prophylaxis, which had been a focus, especially for low income or with the decreased availability of the drug, they had explored it in more details, and evidence-based had been added. Immunosuppression is, as I mentioned, is a focus of new therapy, and it's something everybody is looking to. There was a nice question being raised: who is the appropriate to be considered for treatment of immunosuppression? A nice paragraph being written, and the most important one I highlighted here is the infant should be considered for prophylaxis with immunosuppression at any time after birth, given the increased risk of intracranial prior to initiation of factor 8 prophylaxis. Yet there is no great evidence, but that's something being recommended as one of the things can be used for infant. But more details about when to use, which is the group, as been mentioned by Paul, still the acquired factor 8. It's not been approved, but there are a good body of evidence about that. And another graph, which again I would encourage everybody to look at, which is in chapter 11, looking at the total outcome assessment, which will be one of the tools that you would evaluate your program, your success in running an effective comprehensive program, and that will be good to be looked at and on periodical time to evaluate your performance. I think because of the time, I had skipped some of the slides. I would apologize for that, and thank you.
Thank you so much, Dr. Tariq, for this excellent review of the World Federation of Hemophilia guideline. Thank you. So the next speaker, Dr. Hazza Zahrani. I'm sure everybody knows Dr. Hazza Zahrani. Dr. Hazza, he is a professor at the Al Faisal University and senior consultant adult hematology at King Faisal Special Hospital Research Center in Riyadh. Dr. Hazza, well known locally, nationally, and international. He is a founder of the hematology service in the kingdom with our senior consultant, and he has the credit for establishing the hematology fellowship program. He has many participation and contribution in many aspects, and he was the leader of many committees in the bleeding disorders. He has many publications. Dr. Hazza, he will talk about the gene therapy in hemophilia. So the floor is yours, Dr. Hazza.
Assalamu alaikum. Thank you, Dr. Muhammad, for the nice introduction. And it is a great pleasure and honor for me to present to the colleagues an overview on gene therapy of hemophilia. And I apologize that I may take extra few minutes if you allow, Dr. Muhammad. This is my disclosure. It has nothing to relation to with regards to the presentation. This is the outline of my presentation, introduction. Then I will present briefly some of the clinical gene therapy trials in hemophilia A and hemophilia B, barriers that may be faced with regard to gene therapy, and then conclusion. The field of gene therapy in hemophilia is very active, and if you look into the clinical trials, you would find worldwide there are 13 ongoing recruiting clinical trials that are in the field of hemophilia A or B. And you see here the distribution centers all over the world. We are getting into this. The principle of gene therapy is that you introduce the defective or dysfunctional or replace the defective or dysfunctional factor 8 gene by introducing a gene through a vector into the liver, which results in endogenous production of the deficient protein. And this theoretically may potentially give rise to lifelong and durable treatment through continuous endogenous prophylactic production or prophylactic factor level that will result in prevention of bleeding and improvement of quality of life, and the patients hopefully will have or practice their day-to-day activities like normal. So this is the principle of gene therapy. Why is gene therapy a good target for hemophilia in particular? There are several reasons, and this includes the fact that genes for hemophilia A and B and the factor 8 and factor 9 genes have been described over 3 decades ago and well characterized. The clinical manifestations of hemophilia A and B is due to lack of a single protein and a very minor improvement of the factor level to 1 to 2% will result in significant clinical benefit and transforming patients from severe hemophilia to moderate or mild hemophilia phenotype. And the other point is that it is easy to measure the success endpoint of gene therapy in hemophilia by simply measuring factor 8 or 9 level. So the functional gene, which is called the transgene, is identified and is packaged within a vector. Here in hemophilia A and B, most common vector being used is the adeno-associated virus. The vector is then administered in most recent trials is administered intravenously, and it homes and targets to the organ that you like to target. And here, the most recent clinical trials targets the liver as the site of introduction of the gene of this vector and internalization of the vector into the hepatocytes, which will be endocytosed into the cytoplasm, and then it goes into the nucleus of the hepatocytes. The capsule is digested and is expressed into the cell wall, here the hepatocyte, and is here a potential target for the immune response. And the gene or genetic material here, or the transgene, then either gets integrated within the chromosome or remains outside the chromosome and what we call episomal expression, or outside the chromosome. And the most recent clinical trials use AAV, which actually is an episomal gene transfer where it does not integrate into the chromosome. There are several challenges that would be faced in gene therapy. Is that you should choose the safe and non-toxic vector immune rejection, whether we call it pre-existing immunity to adeno-associated virus or antibodies to adeno-associated virus after its infusion, and the issue of possible rejection, and whether this theory of having a long-term cure is a reality. And there are also ethical issues like the DNA modification and whether it goes to the germline or non-germline cells, and whether it can be shed into the sperms or into the or incorporated into the ova. And the other issue is the high cost expected because of the, what we know from the background about other gene therapy trials in other diseases. The vectors that are used in hemophilia A or hemophilia B are mostly adeno-associated virus, and this is a virus that is not pathogenic to humans, and it has many serotypes from AAV1 to AAV10, and different subtypes or serotypes have different tropism or localization to different organs. For example, AAV8 localized to the liver, others to the skeletal muscles and heart, and AAV5 is used in gene therapy in hemophilia A, and it's localized to the liver. This is another, different locations of the viruses where it goes into both humans and in animal models, showing different tropism, different AAV vectors to different tissue sites. So choosing the right vector is one issue. The other is to optimize the transgene by improving the codons and the promoter that will get the best expression of the protein that you want to be transcribed. And this is done by improving the tissue-specific expression without altering the amino acid sequence of the ultimately produced protein. And these measures have been shown to improve the expression of the deficient protein from 3-fold to up to 44-fold. And you see here, this is a study published in 2011 on codon-optimized factor 8 that resulted in a construct that achieved an unprecedented 29 to 44-fold increase in the expression of factor 8. And this has been used later in hemophilia A gene therapy. And a similar character of the transgene is here used from a case report that was published in the New England Journal of Medicine in 2011, where a family described in Italy had a mutant factor gain function mutation factor 9 called factor 9 PADA1, where this product or this gene has a very high specific activity that was 5 to 10 times as high as the recombinant wild type factor 9. So these are the genes and vectors that are used in the trials and the modifications that people have or scientists have done to improve the expression of the defective gene. So I move now to gene therapy in trials, clinical and human studies of gene therapy, very extensive laboratory and basis and animal studies. So I'll focus on clinical trials. And there are 3 clinical trials in hemophilia A that have been published, but there are many other ongoing clinical trials now. So this is the first clinical trial in hemophilia A, published in 2001 in New England Medicine, where they used an unviral transfer of gene encoding for factor 8 in patients with severe hemophilia A. They took a skin biopsy, they transfected the skin fibroblasts, and then they selected the cells that have been expressing the factor 8, and then they cloned it and expanded it and injected it into the omentum. And you see 3 patients. These are number of spontaneous or injury-related bleeds before therapy, and then after therapy there is less obvious episodes of bleeding. Not very impressive, but it was a good proof of principle. Then this is the second clinical trial where they had 13 patients, and they had a dose escalation study. And in this study, they had an unsustained factor 8 increment. They had 9 patients who change from severe phenotype to milder or even moderate to mild phenotype. And the bleeding frequency decreased in 5 subjects. And this was shown to be safe. And the factor expression was found to persist for more than 1 year in peripheral blood mononuclear cells. And these are patients, 5 patients out of the 13 that has a reduction in their bleeding episodes after the gene transfer. The second, the landmark study that is published in December 2017 was again using AD vector, that codon-optimized vector that I mentioned earlier, where they injected 9 men with severe hemophilia A and did initially a follow-up for 1 year. And they had a dose escalation program. And the 7 of the patients who had higher dose had a rise in their factor level by week 2 to 9 of more than 5 units. And then annualized bleeding rates decreased from 16 to 1. And the factor 8 usage ceased in all patients by week 22. Then they enrolled another patient category at the higher dose. And the adverse event that they observed was a high ALT of 1.5 times and progression of arthropathy in 1 patient who had already pre-existing arthropathy. No neutralizing antibodies were found, and there was sustained normalization of factor 8 and a profound reduction in the patient factor usage. This is a follow-up of that study that was published around 3 years after the initial publication in 15 patients. And the same principle, they found that there is a sustained and clinically relevant benefit with sustained reduction in the annualized bleeding rate and complete cessation of factor 8 prophylaxis utilization in patients who receive more than 4 times 10 to the power 13 viral genome per kilogram. This is from the same study showing the factor level rise. This is on the higher dose that you see there is a very high levels of factor 8 reaching even supranormal levels that declined over the second and third year, but remained also at significantly close to normal or mild phenotype of the hemophilia. This is the cohort 4 that used 4 times 10 to the power 13 rather than 6 to the power 15. And also they had a very good rise in their factor level and factor 8 level that persisted but declined a little bit over the year. The overall results are shown here, where there is more than 90% reduction in annualized bleeding rate and in the annual factor 8 consumption in both cohorts, the higher dose and the lower dose. Biomarine, the company that sponsored these studies, filed an application for the approval by FDA, but unfortunately it was rejected it was supposed to be released in August 21, 2020, but it was not approved because of the fact that the FDA wanted a longer follow-up and observation for 2 years. Moving to the clinical studies of hemophilia B gene therapy trials, there were 8 clinical trials. This was the first study published and first in human trial. They used a retroviral vector, and again they used skin fibroblast. This is published in '93, and 2 patients had an increase in their factor level that lasted for around 6 months, and the clotting activity increased to moderate to mild phenotype of hemophilia. Some of the clinical symptoms were elevated, and the clotting activity has not been increased steadily in the second patient. But no deleterious effects were found in these 2 patients. The second study was published in 2000, and this was an IM injection of adeno-associated virus, and they used a dose escalation program. Initial cohort was 2 times 10 to the power 11 viral genome. And the first patient has no evidence of germline transmission and no inhibitor antibodies to factor 8. There was a modest change in their clinical phenotype where the factor 9 and the frequency of factor IX infusions was reduced, and it was thought, based on this study, that it is possible to transform severe hemophilia to a milder phenotype. This is the third trial where, again, they used AAV vector, phase 1 clinical trial. They used it in a low dose in 3 patients, and this trial showed no toxicities, no germline transmission, and that factor IX inhibitor was not observed in these patients. 2 of the 3 patients had a modest clinical. This trial by Grim Pierce and others was a phase 1-2 study, a recombinant AAV vector, and they infused the vector in the hepatic artery in 7 subjects, and there was no associated short or long-term toxicity, and the therapeutic level was achieved, especially with the higher dose, and the duration of suppression was for 8 weeks. The factor line, this is a very important thing from this study, is that, as you see here in this graph, factor IX activity, which is the red color here, decreased with the rise of the liver enzymes, indicating that the immune rejection or immune reaction to the hepatocytes that are transfected with the AAV has led to loss of the function of these cells. And the other trial here is an AAV vector, again in 8 patients, and again showing the same results of safety and achieving of local gene transfer and the expression of factor IX for around 10 months. Factor IX in both muscle biopsies, this is our IM, and in both biopsies in circulation lasted for more than 4 years. And this is the clinical phenotype of these patients where the factor IX infusions was reduced significantly after the gene transfer. This is the first landmark trial in gene therapy in hemophilia, and this is published in 2011 by Ahmed Tawani and others. And basically, they treated 6 patients with hemophilia, or severe hemophilia, where their factor level improved to moderate form or mild form. And the duration of expression at that time of publication was close to 1 year in most of these patients. This is now showing you the factor IX level that rose. The yellow line is the factor IX level. The dark line here is the enzymes of the liver. And you see that the same idea that was observed there, the rise in the liver enzymes was associated with a decline in the factor level. But here in this study, they overcome this process by treating these patients by prednisone course, up to 6 weeks of 60 milligram daily of prednisone. 3 years later, they published long-term safety and efficacy of this study in 10 patients with severe hemophilia. And there was a consistent increase in the factor IX level to around 5.1 plus or minus 2%. 4 patients who had higher dose had a dose. There was a dose-dependent increase in their circulating factor IX. And there was a clinical benefit where the bleeding episodes were reduced by more than 90%, and similarly, the factor prophylaxis was reduced by more than 90%. But there was a transient decrease in liver enzyme that was overcome by treatment with the steroids. And this is the outcome here again, showing annualized use of factor IX reduced in all the patients, and especially more marked in the higher dose group. So they are reduced in all the patients, and especially more obvious in the higher dose. The second landmark trial here is using intravenous adeno-associated virus bioengineered capsid that has the PADAWA phenotype, and they used that in 10 patients. Again, no serious adverse events was observed. The annualized bleeding rate was reduced from around 11 to 0.4. Factor IX usage reduced from around 3,000 to 50, with a very significant p-value. 8 of these patients did not use the factor, and 9 did not bleed. And there was similarly a rise in the liver enzymes in some of these patients. And this this graph shows the factor 9 rise in all the 10 subjects. And similarly, here there is obvious steroid effect and the effect of elevated liver enzymes and the loss of the activity factor 9. And this is the bleeding pattern before and after the gene transfer. Again, the factor 9 infusion before and after the gene transfer, and the usage of factor 9 concentrate overall usage was much lower after the gene transfer. This is a third landmark trial in Hemophilia A and Hemophilia B, where they used AV5 with liver-specific promoter, and this was a multinational study on 10 patients. No patients had antibodies to AAV before the involvement in the study. They used 2 doses, lower dose and a higher dose. And here there is, again, nearly 80% reduction in the annualized bleeding rate and 50% reduction in the spontaneous bleeding rates, and also more than 70% reduction in both spontaneous and total annual bleeding rate. And this is shown graphically here, the annualized factor 9 usage before and after the transfer, and the annual bleeding rates, as well as the annualized these in different dosing regimens, showing more marked reduction in those who had higher. In summary, the annualized bleeding rate is reduced by nearly 90%, or more than 90% in 3 of the trials, and the factor usage was reduced more than 90% in all the studies. These are many other ongoing clinical trials. 6 clinical trials now are ongoing in Hemophilia A, and 8 clinical trials in Hemophilia B. This is a study using a microsimulation model, where they thought that the lifetime cost saving of gene therapy will be around $7 million per patient, $7 million per patient. These are the barriers that one could face in or think of as reasons to think that hemophilia gene therapy may not be very successful. Is that there may be pre-existing adeno-associated virus antibodies, and this is the prevalence of these antibodies varied from 30 to around 80% in different populations. Long-term unknown side effects are also a concern. Inhibitors, patients with inhibitors are excluded in these trials. Children are also not included in these trials. A long-term durability is unknown, and we know that the Natawani study have a follow-up of median follow-up of 8 years, and the vector expression is on the factor 9 production remains significantly higher than normal, than their baseline. The cost is expected to be huge, maybe a significant barrier, and also the newer therapies like the modified factor 8 001, which can be given every 2 weeks for prophylaxis of hemophilia A. And similarly, long-acting factor 9 products have now been approved for 1 intravenous injection every 10 days. And also other possible competing factors like the generic immunosuppression, which may have a lower cost and may be affordable more than the current price. And another barrier here is what percentage of patients with hemophilia are possibly eligible for gene therapy. You can think that 60% of hemophilia patients are severe and may be eligible. And of those, 30% would have inhibitors. You end up with only 40% of these patients may be eligible. And 20 to 30% of these will have antibodies to adeno-associated virus. And we end up with only 10 to 15% who are potential candidates. And some of them may or may not accept the potential unknown risk for gene therapy. And the patients have to understand the benefit and risk of associated gene therapy, they have to receive accurate and complete information about gene therapy, and they should know how well the other alternative available current therapies are working. And they also should be aware of the level of certainty around potential benefits and the variability of response of different people to different products with regards to the rise in their factor level after the infusion. Follow-up after gene therapy would last for a very long time to observe for any oncogenesis or any other side effects that are unknown. The definition of success of gene therapy may vary from one person to another. Is it enough to have 5 years of suppression, or 10 years, or higher, or the level of factor 8 or 9 rise may also vary, but and some of these patients may still require supplemental factor replacement therapy during surgery. So in conclusion, gene therapy is a very promising therapeutic strategy for patients with hemophilia. It offers a continuous long-term indigenous prophylaxis and possible cure. No inhibitor to clotting factors have been reported in these studies. Long-term follow-up is needed for these patients to ensure safety and observe for any potential long-term side effects. The cost is expected to be a major barrier to widespread utilization of gene therapy. And thank you very much for your attention. I'm sorry I took 5 or maybe 7 more minutes than I should.
Okay, thank you. Thank you so much, Dr. Hazza, for this excellent exploring of the gene therapy. So we'll open the floor for the question. We have a question for Dr. Paul. How effective the DDTB in the gene and the management of acquired hemophilia?
A very good question, and DDAVP and factor VIII together will be of some effect. I rushed through it in my lecture, but in the European registry study, a combination of factor VIII and desmopressin was effective in 68% of the cases where it was used, and that compared with an efficacy rate of 93% with bypassing agents. So clearly a much more and a very statistically significant benefit for using bypassing agents. But if you don't have bypassing agents available, a combination of factor VIII and desmopressin is a reasonable thing to do. But we need to bear in mind that desmopressin does cause significant side effects, particularly hyponatremia. And that's a problem, particularly in elderly subjects. And most of the patients with acquired hemophilia are going to be elderly. So to answer the question, is it effective? Yes, it is. Is it as good as factor VIII, correction bypassing agents? No, but be careful of hyponatremia.
Excellent. So another question for you. How can we manage major hemorrhage in acquired hemophilia, and how can we prevent bleed preoperatively?
Right. Again, an excellent question. I think all of this is covered in the guidelines, which I urge people to download. Personally, what I would say is try and postpone surgery. If surgery is really not needed, postpone surgery until the antibody starts to fall away with immunosuppressive therapy. But if you need to carry out surgery, then I would recommend using surgical doses of a bypassing agent. I would recommend as an initial dose 120 micrograms per kilogram of Novo-7, followed by regular smaller doses of 90 micrograms per kilogram at 3 to 4 hourly intervals. Or you could use 100 to 150 units per kilogram of FIBA, and then use dosing every 12 hours or so. And of course, surgery sometimes may be beneficial. If you have somebody with a malignancy, which is causing acquired hemophilia, removing that tumor, such as a kidney tumor, will actually help cure the acquired hemophilia.
Okay, thank you. The other question for Dr. Hazza. When the gene therapy can be a line of therapy in Saudi Arabia?
I think when gene therapy is approved elsewhere in the world, then it may be available. But the other possibility to have gene therapy is to have patients enrolled in clinical trials. We now have 2 ongoing clinical trials with Pfizer, and we are encouraging colleagues if I have shared eligibility criteria today morning to the colleagues in the WhatsApp group, and if someone has interest, we'll be happy to have, explore the possibility of enrolling these.
Okay. Does the steroid has a role in gene therapy after vector infusion?
Yes, it's very important that these patients get steroid during the rise of their liver enzyme to avoid losing the vector. So this is given around 16 milligrams orally daily for up to 6 weeks.
There is no voice.
Okay.
Something's done. Okay.
Maybe if you allow me until he comes back.
Please.
I have a question for Paul. And now you had covered nicely the factor 8, acquired factor 8. Is the document, I didn't go through the document, address the other acquired factor, the von Willebrand, the rare bleeding factor, acquired factor deficiency?
No, it didn't. And acquired von Willebrand's disease is a very important contrast to make. And acquired von Willebrand's disease tends to also occur in the older population. The good news in acquired von Willebrand's disease is that the titer is normally very low, and it's very easy to overcome the bleeding tendency in acquired von Willebrand's disease because you can saturate the antibody, usually with just 1 or 2 doses of von Willebrand containing factor 8 product. And I have to say also another thing with acquired von Willebrand's disease is that intravenous immunoglobulin is very good. I've used intravenous immunoglobulin alone for surgery in acquired von Willebrand's disease, and it works very well. And the other thing I would say about acquired von Willebrand's disease is that there are 2 types. There's the autoimmune condition, and there's also some drugs seem to cause acquired von Willebrand's, not due to an antibody, but to decreased synthesis, and sodium valproate, so valproic acid for epilepsy is one of those.
Thank you.
This other question for you, Dr. Tariq. The pain management is challenged in some hemophilia patients. What is the best guideline for the hemophilia-related pain management?
I think there is a big chapter in the guidelines, and unfortunately, the guidelines is quite big and addressing many points for patients with hemophilia. I would really, because of the time, encourage people to go through the pain management guidelines and see what are the recommendations that been addressed. Again, it's not much different from other pain management, but there are peculiar situations where you need to use some of the management that doesn't increase the bleeding. Keep in mind that using drugs that may inhibit the platelets may cause more bleeding than only the factor deficiency.
Yeah. Another question for you, Dr. Tariq. If the patient develop inhibitor for factor 8, what is the management?
Again, this is a big topic. Now with the availability of imicizumab, I think life became a bit easy for those who have an access to imicizumab. It can be the drug of, I don't want to say the drug of choice, but it can be the easiest way of handling patients with inhibitors, especially those who have to receive it with frequent episodes of bleeding. The control of bleeding can be done nicely. From personal experience with imicizumab, those who used it almost they went to 0 bleeding, even with an inhibitor reaching to 100 Bethesda unit. So, but talking about inhibitor management, there is a big of talks about the ITI and the use of ITI with imicizumab. Do we need to eradicate an inhibitor with the presence of imicizumab? All these kind of questions being addressed nicely, and there is an ongoing discussion about the methodology and the updates in the management of inhibitor.
If they develop a breakthrough bleeding and he has an inhibitor and he is an immunizumab, can they use factor 7?
Yeah, that's the drug of choice. Although there are some reports coming, we know all that the BCC was associated with microangiopathy and some reports of fatality and thrombosis. Now there are some reports coming with some safety margins, especially if it's used in small doses of BCC and monitored with tests like global tests, ROTEM and thrombin generation. But definitely the most safest type of breakthrough bypassing agent is the recombinant factor 7.
Another question for the panelist. They put hemophilia C, the main factor 11 deficiency. Maybe they ask why we are not mentioned. Just mention factor 8, factor 9. Yeah, Dr. Hazza.
Yes, we have several patients with factor 11 deficiency, and we treat them with mostly with fresh product plasma. We prefer to use SD plasma, solvent detergent treated plasma. We also have used factor 11 concentrate in one patient, but it's extremely costly. One vial costs around 25,000 Saudi riyal per dose. Much less common than hemophilia. Dr. Paul Grandi have some comment.
About factor 11 deficiency and hemophilia. Right. Yes, I mean, it was traditionally called hemophilia C. It's common, and the interesting thing about factor 11 deficiency is that most of the patients have very few symptoms. What is very typical of factor 11 deficiency is that the bleeding is not usually spontaneous. It occurs after trauma, and that also includes, by trauma, I mean even menstrual bleeding as well. And that's because there's the feedback loop with thrombin, and which activates factor 11. And very typical of factor 11 deficiency is that the bleeding is not spontaneous. Few of the bleeds, if you look at all the rare bleeding disorders, the ones that are really serious are factor 13, factor 10 is also common, and to some extent factor 5. Factor 11 doesn't normally cause major bleeding problems, and certainly not spontaneously.
Okay, thank you so much. So it is 9 o'clock now, so we reached to the end. So in behalf of we would like to thank our host, SSBD, and to thank Novo Nordisk for sponsoring this webinar, and also to thank the attendees. On behalf of all the attendees, I would like to thank you, Dr. Paul and Dr. Tariq, Dr. Hazza. Thank you so much, and good night.
Thank you very much for inviting me. It's a pleasure to be at your meeting. I'm astonished to see, I hadn't realized there were over 200 participants in this meeting. So thank you for sharing your evening with me, and I wish you all the best. Thank you very much.
Goodbye. Our pleasure.
Thank you.
Thank you. Very pleased to see you.